All right, let's go ahead and start with a little review before we begin. Washing hands frequently will interrupt which link in the chain of infection? Is it A, virulence factors of the pathogen, B, the reservoir, C, susceptibility of the host, or D, transmission of the pathogen? Go ahead and pause the video, think about this one. All right, the answer would be D, transmission of the pathogen. So washing your hands will interrupt the link between transmitting it from one person to another. All right, in this case, we have a study in which individuals are randomly assigned to receive either a vaccine or a placebo, and then are followed to monitor side effects and effectiveness of the vaccine. Which type of study of analytical epidemiology would this be? Would it be A, experimental, B, case control, C, observational, or D, cohort? Go ahead and pause the video, think about this one. All right, this would be an example of an A, experimental epidemiological study. All right, another one. During the month of May, 2 residents of an assisted living facility with 100 residents developed new cases of sepsis caused by multi-drug resistant Klebsiella pneumoniae. Molecular surveillance identified an additional 8 residents with Klebsiella pneumonia. What is the prevalence of this infection in the population? Go ahead and pause the video, think about this one. Okay, so the prevalence would be 8 because we have 8 people initially infected. We don't know if they developed it here. They probably had it going on, but it's been unnoticed, no signs or symptoms. But then we had 2 extras, so 2 plus 8 is 10. So our answer is 10% because it's 10 out of 100. All right, last one here. Diseases that are always present in a community, usually at low or more or less constant frequencies, are classified as having a blank pattern. Is it A, endemic, B, pandemic, C, epidemic, or D, prevalence? Go ahead and pause the video, think about this one. All right, the answer here would be A, endemic. So when it's at a low level constantly, we call that an endemic disease. All right, chapter 26.2 is very important. We're going to talk about what we call healthcare-associated infections. You might have heard of them called nosocomial or hospital-acquired infections, but it really is much broader, right? It's not just going to the hospital. It is any healthcare setting we can have transmission of pathogens. So this is really critical when we talk about some of the most common cases, so you know what to look out for. And we'll talk about key questions that can help identify the source of healthcare-associated infections and talk about procedures to prevent these from occurring. All right, we have a case study here. We have Stephanie. She's a 7-year-old girl, came into a rural Manitoba hospital. She has to have a tonsillectomy, so pretty standard procedure, right? Infected tonsils, get them removed. She's scared. Her mother's there, though, and she likes her surgeon, Dr. Ryan. He likes to wear these funny bear ties, and she sometimes grab them and, do the kid thing. So, okay, everything seems good. She really didn't like that she had to get an IV catheter that had to be inserted into her arm. It hurt, but she was brave. She didn't cry. So she undergoes the surgery. Everything goes well. She's in the hospital recovering a few hours later. That night, though, the nurse attending her notices that her temperature had gone up to 102 Fahrenheit, which is quite high. By the next day, she has a high heart rate, labored breathing. She goes into pediatric intensive care, and we start empiric antibiotic therapy. So we just start giving antibiotics. Because clearly there's some sort of infection, but we don't know what's causing it. Despite this treatment, her blood pressure starts to fall, and she goes into post-surgical septic shock, and unfortunately dies 2 days later, and they identify it as methicillin-resistant Staphylococcus aureus, or MRSA, and this caused sepsis and infection of the blood, which led to all of these symptoms and ultimately death. The particular MRSA organism that they identified in her blood was identical genetically and biochemically to one that was causing a wound infection in a 57-year-old man 2 floors down. So, is that coincidence? We need to investigate. So this is a hospital-acquired infection, also known as a nosocomial infection. These better termed healthcare-associated infections because really, it can be any provider or facility that is the source, not just hospitals, outpatient clinics, dentists, things like this. 5 to 10% of hospital patients develop some sort of hospital-acquired infection or healthcare-associated infection. That's rather high, I would say. You don't want to go into a hospital and say, I have a 1 in 10 chance of getting an infection from this place. In the United States, we have over 2 million healthcare-associated infections each year, and around 90,000 people die from those. So that is rather shocking, I would say. Most of these are being caused by antibiotic-resistant strains of bacteria. So obviously, people with antibiotic-resistant strains of bacteria tend to go to hospitals because they can't just take antibiotics to get better. That can lead to spread in those locations. And unfortunately, it is estimated that 1/3 of these infections could be prevented by appropriate surveillance and actions by medical staff. So we're talking about 30,000 people dying unnecessarily, let's say. So in our case study, obviously, Stephanie has likely contracted a healthcare-associated infection. There are several common causes of these. We have different infection types. So urinary tract infections, about 20 to 30% of healthcare-associated infections are urinary tract, and they're often caused by catheter-associated issues. So remember, we talked about catheters. You have to have sterile technique going in, and it can move things from the urethra into the bladder. But also, we talked a lot about biofilm formation on catheters. That can take a relatively minor infection and make it difficult to treat, causing it to be much more major. We often see Escherichia coli, so E. coli, and Candida, which are a type of yeast infections occurring in those. Pneumonia, associated with ventilators, 15 to 20% of infections. Inhaling endogenous microbiota, things that are coming through a ventilator that is not properly sterilized or sterilizing whatever's coming in. Surgical wounds, this is a big one. Obviously, anytime you break the skin, you're opening up the body and defeating one of those barriers, one of our major barriers that we have. This is the other second biggest one, 20 to 30%. So urinary tract and surgical wounds. This directly relates to how clean and sterile the equipment is, the technique of the surgeon and those working with them. So for surgery technicians, sterile technique is super critical because you are opening the body. You are exposing it to potentially microorganisms, and that is critical. So sterile field, sterile technique, all super important for surgery technicians. Septicemia, so infections of the blood, less common, thankfully, because this can be very serious, 5 to 10%, often with central lines or catheters, things like that, that are going into veins and blood vessels. Staph aureus is a big one here, MRSA particularly. And then diarrheal infections, again, another big one, usually related to antibiotics. And so we can see things like when we take antibiotics, it disrupts the microbiome of the gut, and that can lead to opportunistic infections. Things like C. diff and stuff like that stick around because they're antibiotic resistant or they're hard to kill, and then we develop diarrheal disease from that. So we'll come back to our case study. Let's talk about a few things here. When we have this type of infection, obviously we want to identify the source. And to do that, we need to ask questions. Sometimes these are hard questions. Sometimes we have to point fingers at people because sometimes ultimately people are the cause of this. Not necessarily knowingly, but that doesn't make the patient any less harmed or dead in this case, unfortunately. So we need to ask things like, is each patient infected with an identical isolate of the pathogenic organism? In our study here, both MRSA samples were identical by DNA analysis, so there's a good chance that they've come from the same source. Has any member of the hospital staff made contact with each of these patients? In our case, we don't know all the details, but we will find those out in a moment. There is someone who has contacted both of those people. So we're thinking that it could have been transmitted from one person to another, probably from the skin patient to Stephanie. You could also say maybe, did all the patients come into contact with the same medical instruments, same lot of medical supplies, fluids, things like this, or the same food or water, or the same place? Did they all go to the cafeteria together, or things like that? Are they eating and drinking the same thing? So did the patients come into contact with each other, enabling person-to-person transmission? Is the infectious agent airborne? Could air ducts be linking the rooms? Could that be the problem? Hospital staff, their normal microbiome. Is this something that someone has on the hospital staff? Maybe it's not causing disease in them, but they're transmitting it to other people. Could it be surfaces, sinks, carts? All of those, you need to test those things. Water is a super common source, right? A common water source here can quickly spread contamination. Were proper standard infection control measures being maintained? That is a great question for this one. That would be things like hand sanitation, hand sanitizers, foaming hand sanitizers inside and outside of each room, use on entry and exit, use of disposable gowns and latex gloves when entering rooms, particularly of immunocompromised patients or patients with dangerous infections, such as MRSA. And then our aseptic technique when procedures are performed, such as inserting catheters here. This is going to protect not just the provider, but also the patients, right? So like we've talked about, anytime you break the skin, and particularly when you go straight into the bloodstream, aseptic technique is super critical. We can't have any microbes entering, so we need to clean the area using an antiseptic, right, to prevent any skin microbes from getting in. Sterile surgical drapes, gloves, things like this, all needs to come from sterile packaging, making sure the packaging hasn't been broken or something like that, because, right, this is a very short route from this this catheter here to the heart and the rest of the body. And septicemia, infections of the blood, travel quite quickly, can be very dangerous. So in this case, we look at who's interacted with both people, and that is Dr. Ryan here. He was examining the MRSA patient, and his tie accidentally grazed the wound area, got microbes on it. He didn't have a protective gown on while he was in that room, and he didn't take that gown off and dispose of it when he left that room. So he's contaminated his clothing. Later, he goes and visits Stephanie, and she's playing with his tie. So now she's getting those microbes on her hands, and then she probably touched her arm because she has a needle in it and transferred those microbes into the catheter area and introduced them into her blood. Okay, and then that led to her death. So we do have someone that did spread this here. They went on to find in this case that there were 5 more patients of Dr. Ryan's who were contaminated with MRSA. And so the doctor, the person who's supposed to be helping them, in this case, was spreading microbes from one individual to another. Unfortunately, this is very common. So this is why proper procedures and protective equipment are so important. It sucks because wearing gowns and things like that, we think of it as wasteful or expensive, but is the expense worth a little girl's life? I mean, that's the question we have to ask here. So this is one case within a facility, but we can also see what we call daisy chain nosocomial infections. This happens particularly when either patients or staff move between facilities. And we saw cases of this particularly early on in the COVID-19 pandemic. The first cases in the United States started in nursing homes, and those were brought in by staff, and those staff moved between facilities and spread it between facilities. Here we could have something like source. So somebody comes in and brings it in. So in this hospital, we had 19 cases of a disease in 56 months. This is probably a long ongoing disease. We take a patient, they get transferred to a nursing home, and then we have an outbreak of 14 cases there in 22 months. Here we have different patients, number 2, number 3, and number 4, all go to different locations. This one goes to a nursing home, this goes to a different hospital, this goes to a even different hospital. You can see new cases in each of those places. Continuing on, right? This person probably got sick again, had to go to the hospital. They got transferred, somebody else spread it. And so, right, we started with one initial case, and it multiplied in one place and then was spread by different individuals to others. And in this case, it was by patients, but could be staff members as well. Here, this was multi-drug resistant Salmonella enterica. And it's not just that it's then continuing to be in these hospitals, right? These people could then go home and spread it to their family members, and they could spread it to the community. So, or staff could spread it when they go home and spread it to the community. So it is more worrying than just in the healthcare setting. It can easily move outside of the healthcare setting in this case. All right, it's been all doom and gloom. Not to be a downer here, but yes, it's very, very important, right? But there is some hope. We are becoming much more aware of this. We're training to prevent this. So we are seeing declines in this. Since 2008, we've seen a 30% decline in healthcare-associated infections. That's great. Hopefully, it will continue to decline. All right, so important chapter, talking about healthcare-associated infections, thinking about how we can track those and how they might be spread and what kind of control measures we can take for those. And then thinking particularly about preventing those daisy chain infections there. All right, that's it for 26.2.